Hey, welcome everyone. I'm your moderator for today. I'm Susan Racette. I'm a professor in movement sciences and of nutrition in the College of Health Solutions at Arizona State University and also a fellow of the Obesity Society. I study the metabolic influences of dietary interventions and exercise training on cardiovascular health and health span. So I'd like to thank you for joining our Health Talks webinar brought to you by the College of Health Solutions at Arizona State University. Our college works to address the challenges facing people and communities to stay healthy, improve the health, and manage chronic disease. And these health talks are one way we serve the community with timely and relevant educational information. So please note today's health talks is not eligible for continuing education credits. However, this applies only to this specific webinar and does not affect the continuing education accreditation status of any past or future webinars in the series. So first, the session is being recorded and will be posted on our website, asuhealthtalks.com. And after the main presentation, we will have about 20 minutes for questions and answers. Please submit your questions using Zoom's Q&A feature and not the chat box. Please register your attendance today using the self-check in link posted in the chat so we have an accurate record of who attended today's webinar. And finally, those of you attending live will receive a brief survey asking for your input about today's webinar. We appreciate your feedback to improve our series. So I'm so excited to introduce today's speaker, Dr. Erica Forzani, a colleague and friend. Erica is a professor in the Phoenix Children's Research Institute College of Medicine, Phoenix, University of Arizona, and an affiliate at the Department of Pathology, Phoenix Children's Hospital. She is also a research professor at ASU. With a formal training in clinical chemistry, an empirical training in engineering, and a passion for health, her lab's philosophy is to identify real-world needs and then invent solutions to meet those needs. So we're so fortunate to have Erica with us today. As we explore combating obesity, we manage what we measure. So in today's webinar, we will discuss how objective metabolic assessment can transform obesity care from generalized recommendations to personalized data-driven interventions. So I'm just going to share with you a little bit about obesity. This is a topic near and dear to my heart. And so if I can share my screen here, let's see. Okay, so hopefully you're seeing that. So I just want to highlight some of the important aspects. Let's see.
Yeah, we're not seeing that yet. There you go.
Are you seeing it now?
We are. Thank you.
Great. Okay. So why do we care so much about obesity? Well, one of the issues is that this is a very prevalent condition. And many of you might have seen these obesity maps, as we call them. They're published by the CDC every year. This is the most recent one that was published in December 2025. And what it highlights is the prevalence of obesity based on self-reported height and weight among adults throughout the US and territories based on behavioral risk factor surveillance system data. And what this graph or this map shows, based on the colors, the degree of obesity or the prevalence in those particular states. And what's notable is that in every state or territory for which there is data, the prevalence is at least 25% or higher, meaning of the adults residing in those states, at least a quarter of them have obesity based on BMI criteria. And as you can see, for some of the states, as the colors become more red and even darker, the prevalence exceeds 35 to 40% and even above 40%. So this is a very prevalent problem. I began studying obesity back in the late 1980s, early 1990s, and the problem has actually worsened in that ensuing 35 plus years. But so why is it a problem? Well, this graph from the European Association for the Study of Obesity shows that so many different organ systems and parts of our bodies are affected adversely by obesity. This particular figure is for females. The one for males is nearly identical with the exception of some of the specific reproductive and cancer consequences. But essentially, as you can see, pretty much all organ systems and tissues are affected adversely by the presence of obesity. And that's why it's so important to assess it and to address it. And again, this shows men. So I'm going to stop sharing there, and I'm going to turn it over to Erica. So now I'd like to welcome Erica, and so she can share her slides. And as she's pulling that up, I just want to thank you, Erica, and others. And if you haven't already done so, to please register your attendance.
Okay. Well, thank you so much, Susan, for the introduction. It's an honor for me that you are introducing me because you are one of the most dominant, researchers in this area. So it's really a pleasure to be here today and have your introduction. I feel honored for it. Thank you so much. As Susan said, we are going to talk about obesity and specifically the concept of how we can manage obesity through measurements, metabolic measurements. First, I want to disclose that I will be referring to a measurement, indirect calorimetry, and I am the co-founder of TF Health Corporation, doing business as Breezing, who is that is a company that developed an indirect calorimeter. But anything I said related to this device applies to any device and the measurement itself generically. So please, consider that into account. I want to be unbiased in this case because it's such an important problem that could be afforded basically with any indirect calorimetry device to perform either research or patients' treatments. So why the title of this talk, We Manage What We Measure? So I knew the quote, but I did a little bit of research on who invented this quote. And basically, the history goes back to a long time ago, 1883, with William Thomson, who was a very famous physicist and refers to this quote in one of his talks when he was referring to electrical units of measurements. And as you know, today we manage our electric cars or our electric bills because we are measuring watts, volts, amperes, right? So we also know that the best example we can take from health aspects is the fact that we are having artificial pancreas nowadays, and many people are wearing those with insulin pumps delivering in a closed loop system, the insulin necessary for maintaining glucose levels in a management range, thanks to the technology of continuous glucose monitoring. And this is evolving every month. Basically, we can see evolution of different versions of glucose sensors coming out and more integrated pumps, a smaller size, and so on. So this is very interesting because technology is progressing and helping patients to manage their diabetes disease. So this is a clear example of that we manage what we measure, and we are referring today to the obesity epidemic. As Susan mentioned, this is a very serious problem. We consider obesity when BMIs, body mass index, are above 30 kilograms per square meter. And we are not even discussing the overweight, because when we go into overweight, the numbers pretty much double. But we can see that the prevalence is very serious, except in some Asian countries and some countries in Africa. This is a global problem. So it's a problem, as Susan mentioned, because obesity affects and impacts so many different organs and brings us so many chronic diseases that are associated to obesity. Why we are talking today about measurements, metabolic measurements? Because by measuring, we can treat obesity, and we also can reverse these high body mass indexes, right? And that is the first line treatment for any of these diseases. So when we approach the problem of weight management, it's very common to find people wondering, how much should I eat? How much exercise should I do? Why my body weight is like a yo-yo? And really, the problems come down to the specific problem. Number one is to what we name metabolic adaptation. In general, when someone goes into a caloric deficit, either reducing calories or increasing activity or combining both, there is a response from the human body where we decrease what we call metabolism, but scientifically is named resting metabolic rate or resting energy expenditure. So we refer to these two terms as equivalent terms. So there is an imbalance of hormones in the body that goes together with this decrease. And this decrease has been reported largely. I'm going to mention more current references shortly. So this is the problem number one. We adapt, the body try to adapt to this caloric deficit. Problem number two with obesity is metabolic inflexibility. So with obesity, we have a reduced capacity to oxidize fats. So it means that when we have availability of carbs and fats as a source of energy, instead of using both of substrates reversibly, depending on the abundance, we use dominantly carbohydrates, and there is a reduced capacity to oxidize fat at cellular level. So one of the champions in this field, Dr. Eric Rabusin from Pennington, who I think is a close friend of Susan, has written this review that is very interesting because he presents his perspective of indirect calorimetry as an indispensable tool to understand and predict obesity. And throughout this talk, we are going to touch different examples on why I consider this is totally true. Okay, what is indirect calorimetry? Indirect calorimetry is a measurement where we indirectly measure the calories generated by the human body indirectly. And this measurement provides two main indicators, which are resting energy expenditure that we can use to provide personalized caloric intake. Sorry about this repetition there, and to also track metabolic adaptation. The second parameter we can measure with indirect calorimetry is the respiratory quotient that can help us to determine metabolic inflexibility or flexibility. As I mentioned, we measure kilocalories per day generated, and this is a reflection of the ATP production rate, which at cellular level depends from the oxygen consumption rate and carbon dioxide production rate when we oxidize carbs, fats, and proteins. This is known as a VO2, oxygen consumption rate, and carbon dioxide production rate is VCO2. And these two parameters are directly involved in the Weir equation, which is a famous equation that has been practicing for over 100 years. It was validated against direct calorimetry, proven to be a very accurate method to determine kilocalories per day and therefore the resting energy expenditure, which is the energy that we spend at resting to sustain our metabolic functions, the different organs functions, and also sustain, the activities through the day. But if we measure at resting, okay, we can get this measurement, which is a significant portion of the total energy that we spend in the day. So the second parameter, respiratory quotient, is the ratio of VCO2 and VO2, and this number, depending on the range that we get, indicates the percentage of carbs and fats burning relatively. So it's useful for the diagnosis of metabolic flexibility or inflexibility. So I had the honor to work with a team that could create a more portable way to perform this measurement of indirect calorimetry. We created this device named Breezy that takes the measurements in a 10 minutes breath test, and you can see it has a relatively light, I have it here with me, a relatively light detection unit with a silicone mask that is reusable and a one-time use sensors that measure the oxygen and carbon dioxide gases. So, but as I said, any other instrument that use indirect calorimetry, such as, for example, metabolic cards, can also provide these two fundamental measurements used to manage obesity, resting energy expenditure, and respiratory quotient. So this device was invented at ASU lab, and you can see it has a bunch of sensors. So it's a multi-scale, multi-dimensional, multimodal sensing with different sensors that allows to obtain the oxygen consumption rate, carbon dioxide production rate at a standard temperature, pressure, and dry conditions. So we validated the device with a gold standard method, Douglas bag, and you can see the correlation parameters are pretty good. So this device provide an accurate measurement of VO2, VCO2, and resting energy expenditure. And we also compare the performance of the device with a metabolic card, assessing similar conclusions. So basically what we have is here a mobile tool that is much smaller than a metabolic card, performing measurements with similar accuracy. And there is some advantages that comes with a smaller size that I don't want to go into details, but I can simply say that the device connects with an app through Bluetooth, and the app provides reports together with Excel files or reports for patients that are very convenient and easy to manage. I have to make a distinction that the accuracy that we get with measurements of oxygen and carbon dioxide is very important because we are considering the full equation. There are other instruments in the market that only measure oxygen, and therefore there is an assumption for obtaining the VCO2, the carbon dioxide part, and this is I would say most of the handheld instruments and small desktop instruments are on this. So for this audience, I would always recommend, if you buy an indirect calorimeter, to check that you have the capacity to monitor both of the gases to obtain maximum accuracy in your measurements. As we said, the resting energy expenditure comprises a significant percentage of the total energy that we spend in a day, that and is added to the physical activity. For us sedentary workers, without counting the exercise that we may do structurally outside our offices, in a day of non-exercise, resting energy expenditure is about 80 to 90% of this total energy expenditure. And therefore, in this case, this is relatively accurate to perform estimates of total energy expenditure. So if we get to know the resting energy expenditure, we can estimate the total energy expenditure, and therefore we are in the position to prescribe caloric intake. So as you know, the caloric intake, if we equal with the expenditure, will be able to give us, take us to a weight maintenance range. So what happens when someone goes into a weight loss plan? So we are initially balance intake and total energy expenditure, and then we typically reduce calories in the food, right, to create this deficit, and the remaining energy is provided for the tissues in our body, and we want dominantly to reduce adipose tissue, so get the extra energy that we need to live, right, from the adipose tissue to lose weight. So typically people goes into a weight loss plan, they lose weight, and then soon there is a plateau. Even though they still continue doing a low caloric intake, there is a plateau that comes as a consequence of the reduction of the resting energy expenditure or resting metabolic rate. So you can see here numerous references related to this problem that we call metabolic adaptation earlier, but there is hundreds and hundreds of these references reporting this problem. This problem can happen in individuals, but obviously is personal, right? So we need to measure and follow what is going on with the resting energy expenditure over time to know exactly if the person is adapting or not. But it's a probability, there is a probability of adaptation, and therefore the person will plateau the weight if this happens, right? So we cannot go against the nature, but what we can do is measure it, right? So if we measure the resting energy expenditure at the beginning of the weight loss plans, and then we measure it again when the person has lost 5-10% of body weight, typically around the months of initiated a weight loss plan, right? We can measure again, and then if there is a decrease, right, we can make decisions to mitigate it. So typically the motivation comes with emphasizing the importance of the physical activity at that point, and eventually if physical activity is reinforced, then the metabolic rate will increase at some point because of the generation of more vascularization for exchange of gases and the increase of muscle mass. So here is an example of a male that lost weight, reached 27 pounds, reached the target weight, but this person suffered a metabolic adaptation after the months. And we can see here how the app, in this case, Breathing, displays the measurements versus what it would be the predicted Mifflin-St. George equation. And we can clearly see here the adaptation. So for this case, at the months, what it was recommended, it was the emphasis of increasing physical activity. I have the picture here of two big ladies. One is Dr. St. George, who is a personal friend as well. And I always like to bring her picture next to her equation because her equation, Mifflin-St. George, is the most used equation and the most accepted for overweight, obese populations. And we have here the picture of Dr. Barbara Ainsworth, who I had the honor to work with at the beginning of the breathing journey. And from her, I learned how we can adapt the use of resting metabolic rate with estimations of exercise activities. So I'm bringing here a link that is in the webpage of breathing.com, but if you use any indirect calorimetry and calorimeter and you know the person's metabolic rate, for example, we have measured for 1,630 kilocalories on a sedentary female person, and this female person likes doing brisk walks of 60-minute total to take out the doggy, right? So the combination of the exercise type that is tied to the metabolic equivalence from Dr. Ainsworth's physical activity compendium together with the time can provide us a personalized estimation of the exercise energy expenditure, which can be added to the non-exercise day total energy expenditure, where we consider sedentary lifestyle factors, so that we get two metrics here for the exercise day and the non-exercise day. So the golden rule for losing weight, let's say this lady wants to lose weight about 1 pound per week. We are not bomb calorimetrists, but for starting, most of professionals consider a deficit of 1 pound per week if the metabolic rate is in a reasonable range to start with a deficit. So therefore, we can pretty much obtain right there the personalized caloric intake for exercise and for a non-exercise days after we have measured and assessed the conditions of this person. So this is how we tied the two smart ladies here and the metabolic rate measurement. How we can introduce all this knowledge into the clinical practice. Here is what I call the thermodynamic approach to weight management and how you could do it if you're practicing this. So let's say we come to the first appointment, and first appointment will take us to steps 1 through 3, where we measure resting energy expenditure, respiratory quotient. With this assessment, we can get to know right away if the metabolic rate is high, low, or within the expected range for the predictive value. With respiratory quotient, we can also assess if the person is with overnight fasting, the metabolic flexibility, according to Dr. Eric Rabusin, we expect a value of 50% carbs and fats for overnight fasting, or towards fat burning if the fasting has been longer, and this indicates a capacity of burning fats. Then we can estimate the total energy expenditure and determine the best personalized caloric intake. When the person goes home, right, we can prescribe specific diets or approaches to meet this personalized caloric intake. But the most important here is make sure that the person has the appointment for the next measurement at about a month. In a month, it's important to remeasure, right, to track for metabolic adaptations, and then based on that, adjust the activities levels, or sometimes the diet. If the person has other preferences, maybe it's a good time to make some changes in the items of the diet. Okay, this will be the circle, right, to complete steps 1 through 5. It's convenient to monitor from time to time these measurements throughout the process of weight loss. Based on our experience, the repeated cycle takes to multiple measurements over the course of months. And when you have that, it becomes very important because we are at the level where we are able to predict weight gain or weight loss for the individual, since we are collecting cumulatively these measurements. So we are going to go very quickly now through different case studies that we have performed with this energy balance concept. 4 will refer to weight loss, 1 will refer to weight gain, healthy weight gain, and I hope not to be that fast or not to be that boring, so you can follow up. But basically, the first 2 cases, the first case was the previous male that I showed that had successful weight loss. Here I'm presenting 2 cases more. One case number 2, is with a study that we performed in Tucson in a low-income community, and 40 subjects with a BMI higher than 25. And most of the subjects have type 2 diabetes or were at risk of type 2 diabetes. This study lasted for 6 months, and we have 2 groups, control and intervention. The control group and the intervention group both had a Wi-Fi scale, so they were weighing themselves every week. They had also a calorie counter app. So we provided an iPad for that, and we provided physical activity trackers. And the intervention group on top had 1 indirect calorimetry in their possession. So they learned how to use it, and they use it at home weekly. So we were collecting at least weekly measurements of weight and metabolic rate in the case of the intervention group. The control group was prescribed originally with caloric deficits from the equation. and a deficit, both had a deficit of 500 kilocalories. So what we observed at the end of the study is that the intervention group had an 89% of weight loss, while the control group has 55% of weight loss. So, and even 40% of this group had a weight gain. So when we went and dig into the primary reasons for these differences, we realized that the equations were, overestimating the caloric intake for those individuals that couldn't lose weight. So that was an evidence, and since the group, this is very anecdotal, but the control group people got to know that the intervention people were using this device, so then they got interested, and we had to provide devices to each of the other 20, so they did their own study, and they learned about calories, indirect calorimetry. But it was very interesting because laymen, from low-income community participants got to learn, and they were very empowered with all the knowledge from the study. So overall, what we observe is that with the measurement introduction in the intervention group, there was a good percentage of weight loss cases, and also better adherence to healthy behaviors. For example, 50%, in average, 50% of the caloric intake diaries were complete for this, 6 months period. So it was very impressive what the measurement effect had in the calorie counting and adherence. So in addition, as we know, if there is weight loss, obviously there were many improvements in the metabolic factors in blood and physiological factors. With the study 3 is very quick. It was ASU, an athlete that needed to lose weight in a very tight timeline. So this was 9 weeks timeline for 10 pounds loss. So we provided the measurement and the device. This individual also did the measurement by herself, and she was tracking her calories using a physical activity tracker and tracking her weight. So overall math here, she ended in these weeks with an average of deficits of 460 calories, which is about which allowed her to lose the 10 pounds. So the day of the competition, she could classify for the category she wanted, and she could basically lift her own record. So it was very, very interesting case because she was stressed and she could make it. So this is, an example on the application. Another example that I want to bring is weight gain. So in pregnancy, we had a study with Dr. Corey Wisner, where basically the study was trying to prove what is the value of indirect calorimetry in the case of pregnancy, since we have such an important problem. 50% of pregnant women are overweight, right? And they end with any of these problems that we see right here. So we know that there are very well-established recommendations from the National Academy of Science on what is the kind of healthy weight gain that the moms should have during their pregnancy. And this is based on the pre-pregnancy body mass index. So basically we come to the point where in the second or third trimester, there is a well-defined kilograms per week gain allowed, and we have a very well-defined caloric surplus for that period of the pregnancy. So we went ahead, we measured pregnant women with the same tools. In this case, the women will do the measurement every Saturday morning. And this is an example where we see increased weight, and we can see in blue trace here the changes of metabolic rate. So We expect increases if someone is growing a new life, right? So we observe that in this first case, but we also observe fluctuations and decreases based, for example, on a cold flu that this mom had towards the end of the pregnancy. So if we use the weight and the predictive equation, you will see here overlap in gray that we will be underfeeding this mom if we would have taken the REE from the calculation, or will be a risk of overfeeding the mom if we would have taken the equation, the predictive equation value when we do comparisons, right, of the measurement REE with the predictive value. So this demonstrates that, there are fluctuations we cannot capture with the weight measurements. And here, just for a quick view, we have 3 cases. These are REE's measurements during the pregnancies, and we can see that the previous case, this is the previous case, there was an increase and then a slow decrease. For this case, you can see there is basically, in average, this mom had her entire pregnancy with no change of resting energy expenditure. These were subjects that were measuring at a point in pre-pregnancy, and we have very well characterized resting energy expenditure. And then this third case, you can see that there was, in this particular case, there was a significant weight loss at the beginning of pregnancy due to nausea. This decreased the metabolic rate, and then the metabolic rate remained lower. So we cannot predict how the metabolic weight will go in pregnancy. In this case, there was a loss of significant muscle mass. In all cases, the babies were healthy babies. And the moms were very happy to have all these tools and were very adhesive to the measurements and regime. In 2 cases, underweight, normal weight, I can show you that the mom could recover a few weeks after giving birth the original pre-pregnancy weight. And in another case, we have the mom with the first pregnancy, and the mom could reach the pre-pregnancy weight before becoming pregnant again. So this tool helps, the mom to manage the weight before going into a second pregnancy. Another hot topic where we can apply indirect calorimetry is in the use of GLP-1. We are working with Mayo Clinic, and here is an example of a patient under GLP-1 for a year. So what we can see here from the app screenshot is that this person started with a 39% decreased metabolic rate with respect to the own predictive value. And during the course of the treatment with GLP-1, there were fluctuations, but overall, after the year, this person reached to 8% deviation, starting from 39. So overall, there was a nice increase of metabolic rate for the period of the year. And what we could also observe in this particular individual, that the fat loss was the principal cause of weight loss, and she could maintain muscle mass because, the special diets with high protein diet and so on. So this is an application that will become soon, hopefully, in a publication. And then, so what is next in weight management? So, all right, one point is what I mentioned. If we accumulate measurements, we can get to points where we can use algorithms. We can use the math, right, to predict weight loss, weight gains, periods in people. And the other important thing is childhood. For me, childhood becomes dominant, and this is why I transition into from ASU to Phoenix Children Research Institute, because I'm very dedicated to pay attention to children. Children also have a high percentage of obesity rates that are increasing. So we had 160 million in 2020, 206 million worldwide in 2025, around 15 million children obese in US. And this is the prediction for 2030. And we have same kind of chronic disease appearing. Believe it or not, I was shocked to learn that there are children going through bariatric surgery, and this is a life-changing event for them because it changed the course of the metabolic health in their life. So yeah, obesity is a big problem in children. So how many calories do we provide to children? So the device I presented was FDA clear for adults, but we came with a nice ways to introduce the concept of metabolism to children, and we got them to measure the resting metabolic rate using our device, but also, in parallel with metabolic cards or Douglas back methods, balloons that we brought, with smiley faces, and we got to validate in children 4 years and older together with University of Buffalo colleagues. So we were confident, and now we have at Phoenix Children, children that are following diets that are healthy for healthy growth, right? But with a total caloric intake that is personalized for sustaining their weight loss. So there are some tools where we can include a shopping list for the parents so they can meet the diet. So my vision for this is, introduce indirect calorimetry in the clinical practice at the hospital. I hope that through this measurement, we have one day the children teaching the parents about all these concepts, right? And we can start from there. I always say that I learned that smoking was very bad at the school, so that's why I hated really, I must confess, I hated the fact that my dad was a smoker, but with persistence, I could make him quit because I knew that smoking was bad for our health. So we hope that the children get to this point to teach the parents. So we know that we manage what we measure. In this case, we can manage weight through indirect calorimetry measurements. And this is the message that I had for today. I am very grateful with the team. These are the current faces, people I work with every day, but obviously there are amazing collaborators and many more people I have worked with in the past to achieve this, this state. Well, thank you for your attention, and I'm happy to answer any questions.
Thank you very much, Erica. So we're going to turn to the questions. So I have a couple here. So the first question is about VO2 versus VCO2. Is the O2 gained part of our breathing the air, or is the O2 also what is in the food? And the carbon in VCO2 is the byproduct of the calories burned from ingested food.
So the VO2 is the basically coming from the difference of the oxygen concentration of what we inhale minus the oxygen concentration of what we exhale. What we exhale is the most important because what we inhale is constant. It's 21% in any part of the Earth planet. So what we exhale, it reflects how much oxygen we are using at cellular level to oxidize the fats, carbs, and proteins. Since there is a relation of the amount of oxygen we consume with kilocalories per volume of oxygen consumed, that's why we can make the conversion of VO2 into calories. Now, the equation is completed with the carbon dioxide portion as well, because carbon dioxide is a byproduct, it's a product of the oxidation process at cellular level, and the difference between what we exhale and what we inhale, pretty much what we inhale is very minimum, and is also in average the same in the entire planet. We exhale largest amount of carbon dioxide compared with the inhalation. That depends on the amount of ATP molecules we create. So both of the components are very important to get an accurate assessment of resting energy expenditure if we do this measurement at resting. And as in the equally to oxygen, there is a conversion of the volume of carbon dioxide that we're breathing out into calories. So there is a factor there that was established when the method of indirect calorimetry was validated with direct calorimetry that measures temperature changes in the human body due to energy generation.
Great, thank you very much. The next question, how can healthcare systems effectively integrate measurement-based approaches to improve long-term outcomes in obesity management while ensuring patient adherence and minimizing stigma?
I think the point is getting to introduce the measurement in the workflow of the clinical practice. I envision that a 10 minutes breathing measurement can be implemented when the person comes in, gets weight, right? Gets the height, and then goes and get the blood pressure. At the same moment, we could get this value. And with the patient education and what is the meaning of this value, the adherence will come naturally. That's what we experienced in this study that we did down in Tucson. We were very impressed with the education and the knowledge level of the participants at the end of the study. With kids, I have experienced it personally. We show that cartoon, right? We ask, okay, do you know what is metabolism? And they instantly, 95% of the cases, they answer, okay, yeah, metabolisms are the calories. Where is the calories coming from? Oh, the calories come from the food we eat. Okay, great. You got it. So, and then the connection with weight comes very naturally. And the parents, if you introduce measurement in that context of kids, parents immediately become interested, right? Is your kid what I'm measuring? So they want to know and they learn. So I think bringing the metric is very important. It's equivalent to bringing blood pressure at the home, right, to control the blood pressure medication, or the glucose measurement, either finger prick or continuous to control diabetes. So I see it as a natural. The more information, the more education, and the more education help us to make smarter decisions in real life. So, yes.
Great, thank you. The next question, is there a particular demographic or individual's characteristics that are particularly resistant to weight loss recommendations via breathing? So such as age, populations with specific diseases or disorders. In other words, where calories in do not equal calories out.
So the only resistance I have experienced with indirect calorimetry is those patients that may be claustrophobic, right? Because I show here, we end putting a mask, and this is for other systems as well, right? You bring a mask where the person has to breathe in and out for 10 minutes, right? We explain that the air is coming through the ambient, is fresh air. But, for people suffering claustrophobia, they are sort of reluctant, and there are tricks where we play music, where we play nice videos to keep them breathing. But this is the highest barrier I found. In terms of diseases, I think it comes to the person itself welcoming the measurement and the curiosity of learn about this measurement. Yeah, personally, what I observe is that the measurement is important because it's the starting point to make that person realized, oh, I was gaining weight so easily because my metabolic rate is low and I need to work on improving it, improving, for example, thyroid, or improving the type of food that I'm eating. And, there are different cases that we come across, but the measurement is the aha moment where people can explain their behavior and the consequence of their bad behaviors. So it's a good education element.
So we used to do, and we've often done practice sessions with people. So not so much if they're claustrophobic, but if they have any just discomfort, and that's with like the canopy over their head, just so that they get familiar with it. It's a familiarization session. So then when we're doing a real thing, they're already accustomed to it. But I love the advances, because back when I started doing resting metabolic rate measurements, it was an enormous cart that took up a big portion of the room. It was not movable from room to room. It took a good hour to calibrate. And it was just I just love all these advances, and the fact that you've validated all these against Douglas bags and metabolic carts and things. So just phenomenal. So I had a question about the intervention group in the study that you mentioned, the intervention versus control, where the intervention group was using the breathing device. They had that to use weekly. So how were they using that information? What were they changing? Were they changing their diet? Were they doing more activity? What enabled them to use that information productively?
Yeah, so they learn so we give them the widget that I mentioned at the beginning, right? So when they will do a new measurement, they will plug in the measurement, and then they will choose, okay, the exercise they will do for the days of exercises for that week, and they will simply follow those caloric intake prescriptions, right, for the exercise, non-exercise day. And they will follow, the best they could based on the measurement. So if the measurement was sort of flat, we didn't notice huge fluctuations in most of the people. But they learned that it was important to measure to know where they were, right? They were comparing with the previous week, they were getting the new one in this week, and they considered it as a dosing mechanisms for their calories. And the dosing mechanism came also intuitively with the exercise. So when they saw, okay, if I exercise, I'm personally burning this much, right? And my partner is burning this much. So they knew there were cases where they were couples, and those were the most successful ones, because they realized, okay, I'm burning differently than my partner, right? If we go on a walk together, we are going to burn different calories. So the dosing and the fine diet component came, naturally. They're learning just from the numbers. They were measuring by themselves. So it was very nice to experience all that learning, and they come in and say, oh yeah, I'm burning differently than, my boyfriend. So it's great to put the tool in people's hands.
That's fabulous. And so I love the fact that you showed the slide of Eric Ravison. And so, yeah, he's a colleague. He's been at Pennington Biomedical Research Center for many years, but he did a lot of his seminal work in obesity right here in Phoenix. And so he was with NIDDK Phoenix for many years, and did, kind of the groundbreaking work with Pima Indians, which is a population that had disproportionately high rates of obesity and type 2 diabetes. And so he really wanted to understand more about their metabolic state and, why they had such higher rates. And so great that you highlighted him.
Yes, and Eric was initiating all this, and we have the metabolic rooms in Phoenix because of his contributions. So we are one of the cities that have these metabolic rooms that are rare to find in the entire country and in the entire world. So
Absolutely. And for those who don't know, so NIDDK Phoenix recently moved to this building, which is the 850 PBC building on the downtown Phoenix campus. They have beautiful new space. They custom designed the entire 7th floor of this building, and they have 3 new whole room calorimeters, beautiful metabolic chambers, an additional smaller chamber, and phenomenal facilities. So lots of advances being made.
yes, beautiful.
Great. Are there any other questions before we wrap up? This was wonderful, Erica. I always learn
Thank-
something and always find it fascinating when you talk about your research.
Thank you, Susan.
So thank you very much. And I want to remind those again, if you haven't already registered, please do so. And so that's all we have time for today. Please go ahead and register. There's a QR code and the link. We encourage you to follow the College of Health Solutions on social media, where you'll learn more about opportunities and talks like this one. Our Health Talk series will continue on April 16th, when our topic will be Understanding the New Food Pyramid, Insights from Nutrition Experts. So that's a very timely topic, of course. Details and registration will be available at asuhealthtalks.com, or you can register now using the link in the chat. Thank you again, and have a great rest of your day.